Welcome all of you to webinar part 3, non-invasive PGT-A. This webinar symposium is supported by unrestricted educational grant from Abbott. Thank you very much. Today, this symposium, we invite 3 international renowned speakers. Professor Carlos Simón from Spain, Dr. Antonio Capalbo from Italy, Igenomix, and Dr. Lu Sijia from China. As you know, the pre-implantational genetic testing for aneuploidy with trophectoderm biopsy is widely used in IVF for detection of aneuploidy embryos. However, the safety concern regarding the biopsy and the unknown long-term effects on the embryos may restrict and limit approaches. So in recent year, a reliable, safe, and effective non-invasive approach has been proposed that the embryo cell-free DNA released by the embryos to the culture medium can be collected and tested during the day 4 to day 6 pre-implantation development. So we are very happy to have this symposium. First, I would like to invite 3 speakers, each of you to use about 5 minutes to give your summary report, and then we can have a Q&A and a discussion. So may I invite Professor Carlos Simón, please. Time is yours, 5 minutes.
Thank you, Dr. Tzeng. All right. So, well, thank you for the invitation, and hopefully next year we will be in person. But this is what we have nowadays. So, what I would like is to make a brief summary of the presentation of the field, which is how to perform human embryo testing. And you have the slide just a summary of how PGT-A has been developed in the last 25 years. And as you see, is technology dependent. We start with fish, then we have the possibility to analyze the complete karyotype through either array CGA, SNPs, or qPCR. Finally, we went to next generation sequencing. The quality of the sensitivity has been improved very much, but we have still we are discarding more embryos than we should. And because of that, because the technology is advancing, we are now in the next step, which is basically the non-invasive PGT-A, which means to be able to do the analysis on the cell-free DNA secreted by the embryo to the conditioned media. And this is the main concept that we are trying to understand now for the best of our patients. So in a nutshell, basically, is moving from the actual situation in which we biopsy the trophectoderm 3-4 cells, we do our amplification, we do our sequencing, and we obtain the results. By doing the same from the cell-free DNA secreted by the embryo, we will get similar results. And this is basically the idea. This concept has been worked by several groups worldwide. And as time goes on, you can see that the concordance has been improved. But in all of this work that has been done, the problem is there has been some manipulation of the embryo, either vitrification, basically the maternal DNA contamination, cyclism. So what we have tried to develop is a system in which we did not manipulate whatsoever the embryo. The embryo has been grown, and then prior to the embryo biopsy, the conditioned media is removed and analyzed. We have presented this in these 3 publications in which we were critics with the technique in the first one because the concordance was very low, no more than 30%. Then we published a pilot study together with the group of Genera Italy with about 100 blastocysts, in what we show the proof of concept reaching this 80% when we analyze day 6 embryos, I mean, after 40 hours. And then we have just recently published this multi-center prospective study with 1,301 blastocysts. This study was done in those 7 centers worldwide, and we analyzed the concordance, but also we just biopsy in a subgroup of 81 aneuploid embryos. What is the concordance between cell-free DNA, universal mass, and trophoectoderm? Just the summary is that in this interim, we have published that we can obtain about 80% concordance, and you can see the difference concordance, sensitivity, and specificity in the 8 centers analyzed worldwide with this number of embryos. And with that, we try to avoid this biopsy. And the second point is that we have created a prioritization system rather than a discarding system, in which we can give a priority of the embryos that they have been analyzed, and then is the doctor and the patient that they have to take the decision according to the age of the patient, the number of embryos that they have. But the information is here according to this prioritization system. So in conclusions, the point that I want to make is that the cell-free DNA produced by the embryo can be amplified and analyzed by NGS, and it's representative of the embryo chromosomal content. Concordance rates between trophoectoderm biopsies and the cell-free DNA, the spent blastocyst media, has been found as high as 85% at day 6 with a mean of 78%. There is a high concordance. The point here is to allow a prioritization system to transfer the embryos according to their aneuploidy risk, and this strategy would avoid embryo biopsy and conflict of discarding potentially euploid embryos for PGT-A. And we are just conducting a randomized clinical trial in 15 centers. This is already ongoing, in which we aim to get more than 10% live birth rate in intervention group, which is transferring according spent blastocyst culture media versus control group. And with that, I just want to leave the session for Q&A.
Okay, thank you, Carlos. Next, I would like to invite Antonio. Would you please?
Thank you, Professor Tzeng. And yes, I want also to thank all the organizer and the scientific committee for this very much appreciated invitation, just very briefly. Yeah, I was asked to talk about the scientific approach behind the embryonic cell-free DNA analysis from spent blastocyst media. And of course, we had several studies over the last decade dealing with this topic and trying to, first of all, characterize what is the main origin and of the cell-free DNA that we can amplify from spent culture media. Of course, over the course of the years, we had to design some specific protocol in both the IVF laboratory and in the genetic laboratory in order to first characterize this type of DNA and also to try to develop optimized protocols that are trying to increase the detection of embryonic specific cell-free DNA. In this very beautiful slide and picture from Elizabeth Hammond, you can see here that we may have many different sources of contamination into the surrounding environment of the embryo. And therefore, a lot of work has been done in order to try to characterize this DNA and to try to concentrate the embryonic cell-free DNA. So what we have actually understood in the course of this experience is that the more the blastocyst is taken into the culture, the longer it stays in culture, the higher is the chance to amplify, to enrich the quota of embryonic cell-free DNA. And also, we have been learning how important is the embryological culture system in order to get consistent result with a trophectoderm biopsy. So as Professor Simón has shown you before, these are the results of a multi-center study that have been recently published. And I think one of the most important points here is the reproducibility of the approach. So once a specific protocol for embryo culture and genetic analysis has been validated in a clinical context, as Carlos was mentioning before, this is extremely important because any minor modification that we may apply or we may introduce in both the embryo culture system, this may have a dramatic impact on the amplification rate and particularly on the concordance rate and the overall reliability of the system. So as you can see here, it was possible, and this is, I think, a great achievement to develop a protocol which is robust enough to be applied in multi-center scale and deliver reproducible outcomes in terms of prediction and concordance rate with the trophectoderm biopsy. So in conclusion, I think that our take-home message from the scientific approach for clinical translatability is that at the moment, of course, we have a kind of potentially lower performance in the prediction of the chromosomal constitution compared to PGT-A, but this will need to be further investigated, where in some situation it can be even the opposite situation. So we, at the moment, I think for we can actually say that PGT-A on biopsies is for sure more robust and validated system for clinical application or for AIDS patients, but non-invasive PGT-A can be a valuable alternative in many different situations. We need to take care to apply transfer prioritization strategies. I think not the selection of embryos, at least at the moment, and at least we will accumulate more data from the clinical side. I think it is extremely important that these protocols, especially both the protocols for embryo culture and genetic analysis, should be validated and developed under clinical conditions. And we should not be translating the evidence from the validation of one protocol to the others, because this is absolutely not possible, because every minor modification in these systems can actually impact the results, the final results. So before being implemented in clinical practices, it's extremely important that that specific protocol has been validated under clinical condition and not under experimental condition where the embryos are manipulated before, like with cryopreservation or biopsies, and then assessed for consistency. And finally, we look forward also to see the clinical outcomes for well-designed trials with that specific protocols that have been developed and incorporated in clinical practice. So this is my summary, and be happy to join the Q&A session.
Okay, thank you, Tony. Very promising summary. And then we'd like to invite Dr. Lu from Shanghai. Your turn, 5 minutes.
Yeah, thank you, Dr. Tzeng, for the introduction, and thank you for the organizers for organizing this. So we have given the talk last week. So I would like to just quickly summarize our main conclusions. So over the past decades, our group in Shanghai, we have developed a DNA amplification method for non-invasive PGT. And we have also done quite some comparison studies of the biopsy versus the non-invasive PGT, as well as the clinical studies of studying the clinical outcomes, the correlation between clinical outcomes and the results of non-invasive PGT. So we have made some summaries that over this past few years. Is that the first is that we found that DNA amplification methods is important in in getting the non-invasive PGT results. So the DNA basically molecules in those culture mediums are very fragmented, and they have you have the short portion and the long portion of the DNA in this cell-free DNA, and it seems that they represent very different origins from the culture media. So that so we don't have a perfect DNA amplification method yet, but I think we did our best to first develop DNA amplification methods. That's actually part of our expertise. We developed DNA amplification methods, and we are still in the process of finding the best amplification method of getting both the short version and the long version, short portion and the long portion of the cell-free DNA. I think that will give more information for us in the future in terms of the embryo viability. And secondly, I agree with Antonio that non-invasive PGT is not at a stage of replacing invasive PGT yet. It's not a method to exclude embryos for transfer. Because in a clinical study, actually in 2 clinical studies that we perform here in China and one outside of China, is that the conclusion is that we still have some false positives. So basically, with the embryos with a abnormal non-invasive PGT result, you will still expect something like a 30% pregnancy rate and a 50% 30% pregnancy rate and a 50% abortion miscarriage rate with basically abnormal non-invasive PGT results. But we do see that non-invasive PGT-A is very effective in terms of ranking of the embryos according to euploidy probability. And the best embryos, with a good non-invasive PGT result actually performs, even better with a invasive PGT, embryo, a normal embryos that is to be transferred. So we got something like a less than 5% of miscarriage rate in that particular group. And we also have the conclusion that it seems that the higher ranking embryos show really significantly improved clinical outcomes in both the clinical pregnancy rate, ongoing pregnancy rate, as well as live birth rate, in an observational study. So, the studies that we perform currently so far. So I think the next stage for this, non-invasive PGT, field is probably first. I do not believe, non-invasive PGT-A will replace PGT, invasive PGT, in the long run. So, but we need to find out the special features in the non-invasive PGT. How is it correlated with the clinical outcomes? So we are currently developing an artificial intelligence, model to study a lot of clinical pregnancies with, at the same time with the non-invasive PGT results. So the features of the non-invasive PGT results can be picked up and to correlate with, our clinical outcomes, including, clinical pregnancy rate, ongoing pregnancy rate, as well as, live birth.
Okay. Yeah.
Yeah, and that's one study that we are currently developing. And then the second one is, I think, a multi-center RCT is very important. So currently, Peking University Third Hospital is leading a 8-center, RCT to study mixed versus morphology to pick up the best embryos for transfer. So we hope that in next year, we should be able to, have a better conclusion of how much, clinical benefit it's going to give us with the non-invasive PGT-A ranking of embryos. Yeah, thank you very much.
Okay, thank you, Dr. Lu. There comes a few questions. There are, because we use spent culture medium for this non-invasive method. So I think most important, how to prevent the contamination of the medium. That's the 2 questions. So maybe initiate what Tony, how to prevent this contamination, maternal contamination?
Well, so far we have not a direct approach that is based on some technologies or the possibility to look for some specific markers or polygenic markers into the genome in order to exclude or prevent contamination. What we have observed in our experience is that you really need to take care of several few but very crucial steps into the embryological protocol, in particular in order to dramatically reduce the contamination level. This is, I think, a parallel experience that we had in both the study by Maria Vera Rodriguez and also my previous experience with non-invasive analysis of embryo culture media, where at the beginning we saw a dramatic level of maternal contamination. This was, as Carlos was mentioning before, was like our first experience, and we were both critical with the approach because we saw this high volume of maternal contamination. I was sincerely really impressed how changing and adapting the workflow of embryology and some few modification also to the genetic protocol at the end resulted in a dramatic reduction of this issue in the current approach that we are using for non-invasive analysis. So I think now the established way is to have a very well developed and validated pipeline into the IVF laboratory and the genetic laboratory, but be very strict and consistent in the application of these protocols. And then in the future, for sure, we have also to try to consider to incorporate some genetic marker that can give us an estimation about the level of potential maternal contamination into this
Thank you.
Cell-free DNA.
Carlos, you have any comment? Because I think the source of contamination may be derived from cumulus cells, granulosa cells, sperm, zona pellucidata. How do you prevent this contamination?
Can you hear me?
Yeah. Yes.
So as Antonio mentioned, there are the obvious mechanical means in the IVF laboratory just to really wash granulosa cells the best that you can, and then to be able to follow the blastocyst for a number of hours, at least these 40 hours. As more developed the blastocyst of the well should be reduced. And of course, you have to handle the embryos in a lab conditions just to prevent contamination, even from the technician, from the observer. So these are the three obvious things to work in a setting as we used to work in any lab. Because interestingly, the embryology lab, our embryologists, they don't use gloves. Sometimes they don't use masks. So all of these things should be implemented, which is the obvious thing to work. So I mean, basically, mechanical means, embryological means, and then of course to improve the amplification protocols, and those are the three bases to improve the technology.
Okay, thank you. So people also always asking why you use the spent culture medium from day 4 to day 6, because at the beginning you used day 3 to day 5, but now you prolong until day 6. Is any specific reason? Anyone can answer this question?
Yeah, I can take that question. So basically, if you measure the concentration of the culture media, the DNA concentration, you'll be able to see that it's actually growing exponentially. So after I would say after day 4, every day of the culture will give you, a lot more DNA inside the culture media. So so from a genetic analysis point of view, it's enough DNA to be able to develop, to be able to give an accurate NIPGT results if we culture to day 6. But so in my opinion, it's it's not wise to force everybody to do day 6, transfer day 6 culture. So we always try our best to get enough DNA and develop a good amplification method so that no matter it's collected on day 5 or day 6, people can still get good NIPGT-A results to transfer. But generally, you get definitely more DNA in day 6. So day 6, it's easier to do, basically.
Tony?
Yeah, we have learned by trial and error, and we have developed the protocols to have a specific number of hours with a specific microliters of the well in order to optimize the amount of DNA. And this should be worked with every clinic that they want to use the system. So again, it's trial and error. We have been learning, as I'm sure that Sijia has been done, by proving many thousands of embryos, trying to see what would be the best.
Okay, thank you. In Italy, one of my friends, Professor Giornorani, he also used like a blastocell fluid for measuring the aneuploidy or euploidy. So do you compare compare this advantage or disadvantage? Because spent culture medium and blastocell fluid is the concordance, or which one is better?
But the thing here is to develop a non-invasive system. If in order to analyze the embryo, you have to go inside of the blastocell cavity and obtain the fluid, then it will be similar to do the trophectoderm biopsy in terms of invasiveness. So that's why, at least in our case, we try to see a system in which the embryo can be grow in the normal situation, and by getting the condition media, we can get this information. But we have not compared the cell-free DNA versus the blastocell DNA.
It's very interesting because about 8 years ago, when Professor Giornorani gave a talk in Aspire, he clearly illustrated embryo biopsy is a surgery to the embryo. So in some religion, some Catholic country, they are prohibit. But you're talking the blastocell fluid biopsy also is invasive method. So it's very strange, very interesting to me. But I agree. So is any concordance rate for this?
Maybe I can add on to that.
Okay, Dr. Lu, please.
Yeah, we try to perform this study actually of the concordance of the blastocell fluid together with culture medium. But honestly, we don't know, which procedure that maybe we did not follow right. We never really got a of the blastocell. So we got something like 70-something% of the amplification success rate of fluid. So in the end, we decided not to continue that study because, like Dr. Simón said, that in the long run, we really want something that is completely non-invasive. So if we put it in like 10 years or 20 years, how the field is going, probably I think everything is gonna be automated. The culture medium is automatically collected and then automatically analyzed. And there is an AI system telling you whether the embryo is good or not, what's the probability of, pregnancy and live birth, something like that, right? So we really want to develop, the system want to go with this direction that it's, in the future, it can be automated. It can, everything is completely non-invasive. And so that's probably our goal. So at that stage, we decided not to go on with the blastocell fluid study. Yeah.
Okay, also notice the Igenomix study already correct something like 1,300 cycles, but it's just in the middle. studies. So already your concordance about 78%. So do you think the final result will come out? I think you just collect part of these the samples, the centers. So when you finalize your result, how many cases you are collecting or recruiting?
We collect, I mean, the study was powered by about 3,000 embryos.
So only halfway. Only halfway, yeah.
Yeah. To consider dropout about 20%. In our case, the dropout has been so far zero, negligible. So we hope to close the study sooner that we plan, with about 2,200 or so. So we are just 2 months away from finishing completely the study. But the most interesting thing for us is about the clinical results. So we want to know what happens when there is a concordance or discordance between cell-free DNA and the DNA coming from the trophectoderm. Because in the pilot study that we published with the Genera group, with Laura Rienzi and with Antonio at that moment, what we learned is that when there is a discordancy and you have a euploid trophectoderm biopsy, but an aneuploid cell-free DNA, miscarriage increases and then ongoing decreases. We want to confirm this. We don't know if this will be the case, but we want to confirm this. And even most important, what clinicians are asking, they want to know what is the results just by transferring the embryo analyzed by cell-free DNA alone compared to doing nothing. And that's why we have the other RCT ongoing, that it will take longer, of course. We just started with that.
Also, I noticed the Shanghai's experience. You correlate the non-invasive non-invasive method with the morphology and AI. So what is the perspective? I think very interesting. From the morphology, AI, and the non-invasive, probably we get more real result. Can you do more comment? Any one of you?
Yes. So currently we have not pulled in the the morphology yet at this stage. So we are still at the stage of collecting basically the so let me start from maybe earlier. So I'm not a big fan of doing comparison of biopsy and non-invasive PGT-A. At this stage, because in the end, some abnormal PGT-A results will also give you clinical pregnancy. So so we are more focused on getting the clinical outcome of that particular transfer. So that's why we collected it's observational study. So for a particular transfer of the embryo, we collected that the NIPGT result of that transfer. So we have already collected almost 1,000 this kind of transfer, and we correlate the clinical results with the features that we found on the non-invasive PGT-A. The features including small deletions, large deletions, mosaicism, and all these features that you can find from the genetic analysis. And of course there are some features that basically each feature contribute to a portion of the euploidity probability. So add up all these portions, we will have a prediction of the euploid probability from calculating all those features. So that's the idea of we have to get enough data in order to make this whole algorithm work. So our next stage is, as Dr. Tzeng suggested, that we also want to pull in the morphology feature of that embryo into this whole algorithm. And we already started to see some interesting thing is that sometimes a top-graded morphology embryos if the score on the genetic side is lower, you have a much lower chance of ongoing pregnancy compared with a much lower morphology grade embryos, but with a higher genetic score. So in the end, I think it's important that we pull in all these factors, really develop a multi-factor kind of an AI system to have a kind of an updated grading of the embryos to prioritize the transfer of that embryos. I think that's the way to go.
Tony, any comment?
Yeah, no, I mean, yes, I agree almost everything what Dr. Lu said, except for the fact that the consistency between the culture media shouldn't be, or at least is not best tested against the trophectomy biopsy, because this is also a matter on, we jump a little bit probably on a correlated field, but this is also how you classify aneuploidies, depending on how you classify aneuploidies into the biopsy. Of course, if you start including less stringent criteria for mosaicis classification, then by definition, you will get inconsistent result between the biopsy and the culture media. I think what we are all interested in testing primarily the meiotically derived aneuploidies. So I think a very fair and robust comparison can still be made, but looking very carefully at the data from trophectomy biopsy. So at least the ones that are most important and most relevant from a reproductive point of view, that are the meiotically derived aneuploidies. That way we can have for sure a fair and reasonable comparison with the non-invasive PGT-A. And of course, I totally agree that at the end, what physicians and patients want to know are the positive and negative predicting values on the pregnancy and possibly at the level of the live birth.
Thank you. Okay, mosaicism usually is a problem to the clinician. Now here comes the question: what is the mosaicism rate in this non-PGT, non-invasive method? Any one of you? From Igenomix, mosaicism rate?
Yeah, basically we are learning. We are learning how to really compare this with the mosaicism that we are getting with the trophoectoderm biopsy. Keep in mind that with the trophoectoderm, we are analyzing 4 cells. Now we are trying to get the cell-free DNA from the whole ball of 100 cells. So now it's a matter to, we need to learn that. I mean, mosaicism took a long time to be developed in the invasive part. And I think that now what we report is what is known in terms of the regular detection limits. But
I noticed the mosaicism rate from Igenomix is not very high, less than about 5, no more than 10%. So I think it's good, because when I look at other systems, sometimes their mosaicism rate is very high. So that is good.
Antonio is our expert on mosaicism. He's the one.
Well, I can give you just a quick answer. So I think that the higher is the mosaicism rate of a program, the higher is the inconsistency of that program. So the error rate of the program. So I think that there are many factors that are causing small variation into the chromosome copy number. And these are not all due to the real presence of mosaicism into the biopsy. So we need to account for that by working with the thresholds that we use in our practice, in our diagnostic metrics. And I think the more we can reduce the mosaicism rate, the higher is the accuracy that we have in predicting, especially the euploid and the uniformly aneuploid embryos. So yeah, I don't think that the mosaicism rate is different across the world, across different laboratories. It's just a matter of how we classify the aneuploidies. And there is no doubt that the more we are using stringent parameter for mosaicism classification, the higher is the predictivity of the trophoectoderm biopsies versus the RCM, and also in relation with the clinical outcome. So Yeah, this is a very quick summary, and this is important because we need first to set reliable gold standard into the biopsy in order to get a fair comparison with the culture media. That's the reason why I was commenting before to Dr. Lu that we need to start first in having a reliable classification of aneuploidies into the biopsy in order to get a fair comparison with the culture media.
Dr. Lu, your experience?
Like Antonio said, actually, it totally depends on. I guess it's not a lab-to-lab difference. It's more of a classification of how you define mosaicism, right? How there's always noise. There's always fluctuations of the sequencing reads, right? So it totally depends on how you set the threshold and how it's a lab practice. So in our lab, in terms of non-invasive PGT-A, we report a 30%. If it's 30% or above of the abnormal that we found, we report as being mosaic. So in that criteria, we got something like 20 something, close to 25% of the, if my memory is correct, it's around that percentage of the embryos being so-called mosaic. But like I said, that's why we believe in AI training algorithm is very important in really telling you whether this kind of abnormality, so-called abnormality, really have clinical differences in terms of when you transfer it into the uterus, whether it's gonna give you, what's the probability of being real euploid or not. So we're still at the stage of collecting all those data.
Yeah, 20% mosaicism is too much. Antonio would disagree with you because this is he's preparing now a paper, and as he said, as high as you get the mosaicism, it means something else. I mean, mosaicism is a figure of 4%, 5%. So other than that, it should be revised. What is the threshold and what is the?
Yeah, it's both the length and the differences. So it's I would say put into, if it's a culture medium test, it's just it's not as easy to define all those characters like compared to an invasive PGT-A.
Okay, so people are always asking what is the priority because they have some mosaicism. What is the prioritization to put the embryo back? Can you brief list the order?
Prioritization, we have learned that with the time, we have learned that, and also as a doctor and yourself, you learn that sometimes it's not the same to have 3 embryos and with a patient with 30 years that can prioritize between euploid, segmentals, and or just a patient with 43 years that only has 1 embryo, which has a segmental or has a whatever issue. So the thing is, most prioritization should be done between the doctor and the patient, and with a clear analysis, having the embryo in the best conditions. So you and me, we have been in meetings that doctors wants to transfer embryos with trisomies, which is kind of crazy. You don't informed decision with your patient, having the best in the technical part that will give you the possibility to do this decision. So again, prioritization should be as logical as biologically, from the biological point of view, but it's not the same, the age of the patient, the situation, that you get only 1 embryo after 4 cycles, and obviously everybody has to take their decisions about that. There are countries that you cannot transfer embryos that you don't think that they are going to make it, though other countries, they allow you to make the decision. So I will leave this to the doctors and patients with a very well technical report that was done with proper evidence-based medicine studies and technical issues.
Absolutely agree your points. Do you have any idea about the methodology to do the non-invasive PGT-A?
Methodology? What do you mean by methodology?
How for machine, or use the instrument, or what is the most important when doing this the step to doing this process, to do the procedure?
Okay, let me give you my own opinion that probably is kind of more challenging than my colleagues. You know, cell-free DNA is changing the way of diagnostics in medicine. An example is cell-free DNA by the trophectoderm, non-invasive PGT. Non-invasive pre-implantation testing has changed the way that we do obstetrics. Liquid biopsy is changing the way that we are diagnosing tumors. And I am completely confident that non-invasive PGT-A will change in the near future the way that we analyze the embryos. Because the trend is through non-invasive, the trend is to go to nucleic acids in fluids, in blood, in whatever, in this case, in the conditioned media. So this is the general trend. And look what happens in obstetrics. Now we are in the first steps of this non-invasive PGT-A. And the next thing is going to be to create machines, first to create good algorithm, as Dr. Lu mentioned. You have to have good algorithms, but then it's going to have a system that you can. The point that I make is that, and nowadays we have NGS, probably soon we will have another nanopore, or we will have another system. If we talk about amplification system, is something that is progressing, but also sequencing is progressing. Algorithms are just, we'll know more about that. So, I mean, the science is absolutely outstanding nowadays, and it is going to progress. But the concept here at the medical level is that non-invasive tests, they are going to take over invasive tests using nucleic acids in fluids. But this is my forecast, okay? This is just...
Okay, here comes the question. Any mosaic rate difference among different IVF labs has been seen from different IVF labs?
Mosaicism should be asked by Antonio Capalbo, please.
So, yeah, can you say again the question? So, what rates of mosaicism are reported between different centers? Well, this is amazing because it can range from 2-3%, as Carlos mentioned before, even up to, I saw even up to 30-35% of embryos being defined as chromosomally mosaic, which is, of course, I mean, we know that it's not the biology or the genetics that is changing between one experience to another, but it's the way as we interpret the result, as we discussed before. So I think with a few more data that we are also producing, I think in the near future, we will really need to standardize this practice and avoid overcalling of aneuploidies in embryos, because this is just, most of the time is an overcalling of aneuploidies in our embryos. And this explains also the few experience of some colleagues, which is known to be opponents of PGT-A, that have been transferring aneuploid embryos with successful live birth, because these embryos were originally euploid, actually, and misclassified as mosaic. So, yeah, I think this is something that really need to be further developed by scientific societies and new updated guidelines in order to really avoid this practice that at the end results in embryo, patients discarding embryos that are completely normal.
Okay, thank you. I also noticed in your presentation, you also mentioned the kind of culture medium, the incubator, or maybe machine, they are not affected the outcome of the PGT-A result. Is that true? Because right now you see Illumina and the Thermo Fisher, they are a little bit different, the machine. So can you give more comment, Carlos?
That's right. In our study, in our multi-center study, we did not find any difference in terms of incubator or the culture media that they were used. And we talk about, I think, 5 different incubators in those 8 different centers and something like 4 different culture media. So at the end of the day, we are detecting nucleic acids there secreted by the embryo. So if we are good in getting that, it should not affect the other conditions that they are going around. I have a slide to share. If you do not mind, I want to show this. Okay,
please. Yeah.
10 seconds. Can you see the slide now?
Yes. Yes. Yes.
Okay. This is just basically, after the publication, we have started to work with different do this non-invasive PGT in a clinical setting. This is called Embrace, the product. And prior to do this properly, the Carmen Rubio team, they do what we call preclinical validations, which is that they have to work with us for a number of cycles. So these are the preclinical validations that the Carmen Rubio team does with every clinic that they want to work with us at the clinical level. So even if in the clinical study, in the concordance study, we showed this 78, look what happens when centers, they try harder to validate their system in terms of concordance. This is the number of cases that they have run. This was the 12 initial centers that they were with us. So if once you go to the clinic and you just learn from all the tricks that we have learned from that, you can see now that the overall concordance rate goes to 84%. Some centers, they're doing good, but to really move to clinical is just to have at least 80% concordance. I just want to show you because this is real, this is clinical validation prior to do real cases in these 12 centers, other than the centers that we did the concordance study.
Okay, here comes a question. Can you please tell me, is the non-invasive PGT is still at research level or can be clinical use?
It's already at the clinical use. I think that both Dr. Lu and ourselves, we are offering this at the clinical use with a previous validation, as you have seen in the slide that I just showed you.
Okay, but still, at this moment, only 80%, roughly 80% concordant rate. So what is the another 20%?
The thing is, yeah, the thing is this 80% is versus the gold standard nowadays. The other 20% is what we are trying to understand with the clinical results, whether this 20% that this is not concordant, it's really could improve the result of the actual gold standard. That's the main difference. The whole blastocyst could be superior or not versus the cells from the trophectoderm. This is what we try to find out.
Okay, there's a board member.
We also follow very similar procedures of studying this, the inconcordant 20%. We got similar concordance of 80-something%, but the ones that are not concordance, it seems that the standard that we're comparing to, no matter it's the whole blastocyst or it's the PGT-A, trophectoderm biopsy, this it's just that we're not sure whether this is really the gold standard. So that's why we took a little bit step further to study the clinical outcome of that particular transfer. So I would say 80% of concordance is, sets a very good standard that we can at least use this to prioritize the transfer using non-invasive PGT-A at this stage.
Okay, there comes another question. Maybe Carlos can explain again. What are the parameters of concordance Professor Simón speak of? He just missed it.
Concordance means that the results.
Parameters.
Yeah, it means that the result of the trophobectodermal biopsy are equal to the one of the cell-free DNA from the same embryo. Mm-hmm. This is concordance.
Is that clear? Claire? Claire is one of our board members from Aspire. Okay. Is any other questions? I think the non-invasive PGT-A is the future. The liquid biopsy is the future because, as we know, the trophectoderm only reflect a part of the embryo, and it not really reflect the real inner cell mass. So I think the liquid biopsy, this non-invasive method, is quite useful in next 3 to 5 years. And if we can, in conjunction with the endometrial resectability analysis, maybe I say this another 20% the importance, So I think we can provide a better condition or better embryo quality for infertile patients to have their babies. Yeah. So is any comment? Each one 1 minute? Tony? Can you comment?
No, I mean, Carlos, do you have something else to say, or Dr. Lu?
I cannot agree more with you. I mean, you just say the word, so.
We all agree.
Yeah.
Well, look, yeah, everyone 1 minute. Concluding remark.
Yeah, my conclusion is just that if we put it in the long run, right? I mean, everything, the way that we're doing things now is that we try to hurt this embryo by doing invasive selection. So in the long run, we really want to, have everything set up, the good algorithm, good automation, good machine, and good practice set up so that every single embryo can be screened before we transfer into the uterus. I think this is the, a general goal of the whole field.
Okay, Carlos?
Yeah, as mentioned before, I think that cell-free DNA is the present in obstetrics, is the present in oncology, and it will be the near future in reproductive medicine. And this is the next step for the diagnostic in medicine. And as such, I think that we may benefit from that.
Yes. Okay, Tony?
Yeah, I mean, I agree. And yes, for sure, we need to keep working. This field is such important for many patients, especially testing aneuploidies in countries where we treat patients of mainly advanced maternal age and where they experience a lot of frustration and once transferring and observing the outcomes of embryo transfer with aneuploidies. So yes, everything that we have in place, we should keep working, put all our efforts, design very well trials, well-performed trials, and provide evidence of this field that is developing, progressing, and delivering reliable and good outcomes for our patients.
Okay, thank you very much for all of you and our audience attend this Aspire sponsored webinar. So I will see you in the very near future. Thank you very much. I will officially conclude this session. Bye-bye. Thank you.
Progesterone is a steroid comprising of 3 cyclohexane rings and 1 cyclopentane ring. It is manufactured for therapeutic use from the wild yam root Dioscorea species. Due to rapid first-pass liver metabolism, progesterone has variable concentrations and very low oral bioavailability. Therefore, it is administered via injection or vaginal route, which are not easy to use and associated with side effects. Dydrogesterone was introduced for clinical use under the trade name Dufeston in the 1960s for treatment of conditions associated with progesterone deficiency. The manufacturing process of dydrogesterone is highly complex. It starts with the chemical modification of progesterone, followed by a critical phase of transformation into dydrogesterone. This is done by passing it through UV light at an appropriate wavelength, intensity and time sequence, resulting in a unique, modified retrosteroid structure. This manufacturing process makes dydrogesterone the only commercially available retroprogesterone. The bent conformation of oral dydrogesterone enhances the rigidity of the molecule compared to progesterone. Due to its unique structure, dydrogesterone is highly selective for progesterone receptors, supplementing deficiency of endogenous progesterone. It has negligible interaction with other steroid receptors, resulting in a lack of androgenic, estrogenic, glucocorticoid and mineralocorticoid effects that can occur with other progestogens. Dufeston, containing 10 mg dydrogesterone in each tablet, is formulated to have good bioavailability, enabling convenient, patient-friendly oral administration. Improved oral bioavailability and the receptor agonist activity of its metabolites causes secretory transformation of the endometrium, progestational activity, at a dose 10 to 20 times lower than micronized progesterone. Various progestogens have been investigated to support endogenous progesterone in the treatment of luteal phase deficiency. Only Dufeston, progesterone, and 17-alpha-hydroxyprogesterone caproate are currently approved for clinical use during pregnancy. In addition, Dufeston has a wide range of indications to supplement endogenous progesterone deficiency. It is shown to be effective in irregular menstrual cycles, dysmenorrhea, endometriosis, premenstrual syndrome, and secondary amenorrhea. In women undergoing assisted reproduction, Dufeston supplements endogenous progesterone and provides orally effective luteal phase support, contributing to successful and comparable pregnancy outcomes versus vaginal micronized progesterone. To date, around 113 million women throughout the world have experience with Dufeston, including 20 million fetuses exposed to dydrogesterone in utero.